called Bringing Life, all about maternity in the UK. What does it mean? Why has it changed? How has it changed? And can we find solutions to how we move forward? Because there seems to be a lot of discontent on all sides. So as part of that, we've got 20 lectures through the year. This is number 11 now of the series. We're very lucky to have Abi Merriel here to speak to us tonight. Even luckier that she already lives in the city, so she's already from here. So, but is one of the experts on antenatal education, which actually is at the very heart of the issue here. How do we best communicate with women who are pregnant? How can you plan together for birth? Who has control in that situation? How do you best discuss what the outcomes are? So Abby's going to speak to us tonight, and then there'll be a chance for questions, both those online and then in person as well. So Abi, thank you very much for coming tonight. Much appreciated, and I'll hand over to you.
Lovely, thank you very much. I'm a bit shorter than you, so I might have to.
Yeah.
Is that all right? Can people see me there? So yeah, Andrew, thank you so much for the introduction and the invite, and thank you so much to everyone for coming in person and online, especially the medical students who've got their exams tomorrow. No pressure there to pass. So I'm here to talk to you about whether antenatal education is indeed the key to unlocking the maternity crisis. But why is it important? Why is this a key part of the puzzle? And I think this probably kind of shows why it might be important. So 1 in 10 women have post-traumatic stress disorder 6 months after birth. And that's just a huge and quite arresting fact, I think. And we need to do better at what we're doing in order to prepare women better for birth, because it might make a difference. So what's going on at the moment that makes this an important topic? Because I think it probably has changed over the last decade. So it feels like a really momentous time for birth preparation and decision making. We've had the recent birth trauma all-party parliamentary group and report, which really put this issue on the agenda, along with the recent maternity inquiries, and there's one that's going on right now, and listening to women's voices in Liverpool just in a couple of weeks. We have this the kind of opportunity to plan and discuss what might happen during your birth can prepare you, and if you kind of have information about your birth and feel more in control of what's going on, then women report that they have a better experience. And birth experience is really, really important to women. It may be even more important now because it's in the public discourse than maybe it was 30 or 40 years ago, when actually it probably was really important. It's just we weren't talking about it. And it can have a real impact on women's mental health. But if we're just thinking about for a minute birth preparation and antenatal education, what are we actually meant to be doing? So those of you in the room who had a baby, say 15 or 20 years ago, will probably remember, if you had a baby in the NHS, being invited to a series of parent craft classes where you went along and you met with your midwife and some other mums around you who were going to have babies at a similar time, and you had a series of classes. And then you talked not only about birth and pain relief, but about postnatal things and how to look after and bath your baby. And over the last kind of 2 decades, this has been massively eroded to what is the current care. And I'll talk to you about what current care is shortly. But what because it's not entirely clear and it's changed a lot since COVID, but what it's kind of boiled down to, as everything in medicine often is what's in the NICE guidelines. And what this is the sum total of what is antenatal classes in the NICE guidelines. So offer nulliparous women, so women in their first pregnancy, and their partners, antenatal classes. And they include topics such as preparing for labour and birth, supporting each other, common events, how to care for the baby, something about bonding and planning and managing feeding. But those 6 bullet points, what does that even mean? That's just that is some total of the guidance that we have. And those of you who have listened to any of the kind of maternity inquiries or work in the area will understand that we've had this real positive push towards sharing information better with women. So it possibly started, I would say, around 2015 with the Montgomery ruling, which was a case whereby Nadine Montgomery went to court because she felt that she hadn't been provided with the information that she actually would have valued to make the decision about her birth. And since then, the law hasn't actually changed, the guidance hasn't actually changed, but the way that we think we should operationalise it has. So actually, it's really changed the world of medicine as a whole in terms of ensuring that people have the information they really need and that's important to them in order to make their decisions. And this has moved us towards having this kind of guidance around shared decision making and consent. Although in obstetrics and maternity care in particular, it's really, the terminology is really challenging. So like throughout the GMC guidance and the NHS England and NHS Improvement guidance, we talk about shared decision making, but that is not the terminology that women and birthing people want to use in maternity care. They don't believe the decision is shared. They believe the decision is theirs and we should be there to support it. So there's an awful lot of kind of discourse around this area that make it really difficult to get right. And it's just so important to women that we actually do get it right. So I've got a blank slide there. So what I want to do with that kind of background in mind is tell you a tale of 4 studies, which are 4 studies that I've done over the last, it turns out, nearly 10 years. But I actually think I could probably stop after the next slide, which is we need to give people information, because actually that is what every single woman and birthing person that I've spoken to actually want. And we need to find a way to do it better. So the first study I'm going to tell you about, and I'll come back to this study a couple of times, is the ACE study, so Antenatal Care and Education. And this was a Health Foundation funded study where we were trying to develop an improved evidence-based antenatal education session. So we started off this study by, this was my first foray into, I might tell you this story actually, my first foray into antenatal education. And the whole reason that I did this is just before I did my PhD, I was the registrar on the labour ward in Bristol. And I was one of my midwifery colleagues was having her very normal labour and birth, except her baby heart rate monitor at some point showed an abnormality in the CCG. And I said to her, I need to do an emergency caesarean section for you, a category 1 caesarean section, which she's a midwifery colleague. She knew exactly what that is. That's a birth within 30 minutes. And she said, okay, but then cried all the way to theatre and all the way through the operation. And then when I went to see her afterwards, because she's a colleague, you know, I remember her to this day, she was like, you know, it was awful. I've completely failed, completely ruined my experience. And I was there thinking, my goodness, I've just traumatized a valued colleague who I really thought would know that this might be a possibility. And if she hadn't thought about the possibility of an emergency caesarean section, and she's a midwife, what about everyone else? And just so everyone in the room knows, we do a caesarean section, an emergency caesarean section of some category, in about 30 and 100 women in their first pregnancies. So this is not an uncommon intervention. So this is why I'm doing this work. So I didn't know a huge amount about it, so we had to start off somewhere. So we interviewed in focus groups 46 women and 21 staff, mainly midwives, to figure out like what people thought of the current state of antenatal education. And what we found was that people felt that there were practical barriers, getting there, time to do it, rooms to do it, issues with engaging and interactive learning. And that was like from the side of the women, but then from the side of the midwives came the idea that actually they didn't really receive decent training in order to be able to do it. And there was this disconnect, therefore, between midwives and birth and parents, And that was, so these women said to me, I just went to this group and the midwife said to me, what do you want to know about? Because the midwife had obviously been taught to say, you're adult learners, what do you want to learn about? You're in control of your learning. And the women said to me, well, we didn't really know what we wanted to know about. We know we want to know about vaginal birth, but that, what else do we need to know about? We don't know. And the midwives are like, we don't want to tell them anything unless they do really want to know it, because we don't want to traumatize them by giving them information about stuff they don't want to know about. And this disconnect was just so stark to me. And that was kind of really shaped the kind of next parts of the project, which I'll tell you about. But the other thing that both women and midwives really identified was the opportunity for social connection, which the parent classes had always given. And it's just, with our society becoming more and more, on your phones and in line and not together, so important. And then the other thing that was really highlighted was the expectations of birth following classes. So that's when we went to do this additional analysis of the focus groups. And basically we found that, education was a source of really optimistic expectations for a natural birth. So many women were going to classes where we were only talking about really vaginal birth, which was physiological and spontaneous, and not really talking in depth about things like instrumental birth and cesarean. So people leave the classes expecting an uncomplicated birth, which is fantastic, isn't it? But when so many women are having some level of intervention, whether that be an induction of labour, an instrumental birth, an episiotomy, a cesarean section, then actually expecting that everything is going to be absolutely physiological is possibly not what we should be leaving them with. And the women really felt that knowledge of interventions and complications as a mean of actually preparing them for making choices and coping with labour and birth was really, really important. And I guess one thing I did that I think really illustrates this well is we showed one of the focus groups, all of them in fact, the labour and birth statistics of the unit that we were in. And it was 3% of women or something had water births. And and a lot of the women in the group actually had wanted to have a water birth because it's seen as a really positive form of pain relief. And she was like, but Abby, if someone had told me that only 3% of women have water births, I wouldn't have pinned all my hopes and expectations of my labour and birth of having a water birth. So just by not giving basic facts, we can really, really impact on women's experience. So we thought, well, we've asked women and we've asked midwives, but we've only really asked postnatal women because only one lovely antenatal woman showed up to our focus group. So we thought, okay, we'll do a survey of antenatal women, and there was 415 of them that filled in the survey that also planned to attend classes. And we asked them, what is it that you want to know about labour and birth? And I think the top one was coping strategies for labour and birth. So that seems really important. But they want breathing exercises, which kind of fits into coping strategies, but they also want information on labour and delivery and pain relief and pelvic floor exercises, things like that. Really core information that people want. But where are they going to get that information? So 2/3 of women that completed the survey were planning to attend more than one class. So not just getting their information from the NHS. And bearing in mind, NHS antenatal education is free and all of the others have some element of a cost to them. So what we saw was that people prioritise things like NHS classes and hypnobirthing and private classes to get information. They prioritise all of them. This light purple line, sorry, not me, but the light purple line here is about meeting people. So that's pretty important in everyone's radar. And then there's other as well, which is pretty important in some things. And that's things like getting some exercise and things which fits with Pilates and yoga. So we're starting to see a real spread of what people were accessing. And then we were, saying, well, what is the issues with accessing antenatal education? And they said, we need better accessibility. So people like people's lives no longer work, that they are willing to come and attend a class that's in a room on a specific time on a specific day, and that's the only option. And they really felt that they weren't accessible. They felt the postnatal kind of part of the journey was missing, and that there needs to be more advice and support when things change. There needs to be improved mental health support, and they really wanted to highlight face-to-face learning. Now, these surveys were done, although they were only published as a labour of love last year, they were done kind of around COVID times. So many of the women had attended some antenatal education before COVID, but they were kind of in that kind of period we were doing the questions. And the other thing that they highlighted, which I hadn't really thought of much before, is that there needs to be like stage appropriate delivery of antenatal education. So some things do need to come in the first trimester and some things need to come later on in pregnancy. So then we asked the people who were delivering the information what they thought. So we got 99 antenatal educators, so midwives, doulas, people who deliver kind of hypnobirthing classes, and asked them what they thought of the current antenatal education. And like 2/3 of them don't feel it meets women's needs. And like over half of them felt there was really big variation in coping strategies education. So there were issues around the adequacy of current antenatal provision. The educators felt like they got feedback that NHS classes were not high quality in terms of teaching style and resources. There's a lack, and then there's the issue about teaching about coping strategies costs money, like as in people have to pay for it. And then actually if you take all the teaching of coping strategies into the private sector, then the people who are actually delivering and supporting the coping strategies, which is the midwives in the labour ward, aren't like experienced and versed in them, so that it's more difficult to support the coping strategies that you then talk about. So we had 819 women complete our postnatal survey, because we thought, well, 46 women isn't a lot. Let's just make sure we're not missing a big trick. And 32% of them felt very prepared for their labour and birth, and 42% felt somewhat prepared. So I think that looks pretty good, right? After their antenatal education, they feel pretty prepared. However, so over half of them expected it to be straightforward. Some, 150 women expected it to be difficult, and some weren't sure what to expect. But of those 800 odd people, 738, they did not feel their birth was as expected. So even though we've prepared them, they still feel that it wasn't as expected. Now, I think 44% finding it easier will probably take that, because that sounds like a really positive thing. But 56% of those 738 women felt that their birth was more difficult than expected. So we're somehow not really matching our education about birth to the realities of birth. There's somewhat of an expectation reality mismatch. So we'd kind of done all this planning and thinking then about our antenatal classes and really focusing on the kind of the whole antenatal education journey. But then we moved on to think about making decisions during labour, because this is a really a difficult time to make decisions, right? So the kind of core principles of consent is that you can take in the information, you can weigh it up, you can ask questions, and you can make a decision. But sometimes that is not how it works during labour, and your decision making is impaired. You're exhausted, you're in agony, you're being asked to make decisions at really a very quick pace. So we started to investigate this. So we just this is an overview of a paper that is about to be published in the next couple of weeks. So I've been relatively scant on details. But we did a systematic review of women's experience of informed consent, including the views from 28,000 women across 47 studies. And one of the kind of things that really got me thinking is that the women feel that consent is constrained and symbolic and not truly informed and autonomous during labour. It's like the ritualistic thing of signing a piece of paper to say that you agree to a procedure, rather than actually being a truly informed and willing kind of willing person having an intervention. And that women feel strongly that it's difficult to have these kind of complex decisions intrapartum, especially when they're acute emergencies. And so it is all about antenatal preparation, improved communication, and getting some level of continuity of care. So meeting the same person more than once in antenatal classes or in clinic is really, really valuable. So we then went on to try and dive into this kind of idea of intrapartum consent a bit more, and we found women who'd had intrapartum interventions, so emergency cesareans. They'd had spontaneous deliveries, but with interventions, for example, induction along the way or augmentation, forceps and instrumental births, forceps and ventouses. And what women said to us was that they just needed information, but they're going to lots of non-NHS antenatal education, which they want to be face-to-face, and that's one of the reasons they're going. But otherwise, there's just too much information around. So they want like high-quality, trusted information sources. They acknowledge the effects of labour, their inability to always focus on the information because they've got lots going on around them, and their memory of events can be tricky if they've been exhausted and in hospital for a while, and that they really need good pain relief in order to be able to have these difficult conversations. But that we need to get better at thinking about how the birth partners in the room can be. And I find this very difficult myself because you go to an antenatal education class with your birth partner and they get told that, support the woman in her choices around birth, for example. Does she or doesn't she want an epidural? Does she or doesn't she want this intervention? But the fact of the matter is, for me as a clinician, and I don't know what you as clinicians in the room feel, is that, if a woman says to me, yes, I do want that intervention, even if her partner's saying no, she doesn't, I'm definitely going to be listening to the woman in that scenario, right? So we need to figure out a way to bring birth partners into this antenatal education and decision-making spaces. And I've got no idea how to do it. So please, answers on a postcard, that'd be great. But what women consistently say, and every time we've asked them in every different which way, is that there are times when unilateral decision-making is actually important. And when there is a true life-threatening emergency, they don't need the illusion of choice. They need us to act fast, and not be having kind of complex consent conversations. They just need the right thing to be done for them and their baby, but good communication around it. But we thought, we've asked these postnatal women who've had interventions, are antenatal women going to say the same thing? Because we keep getting told by healthcare staff that we really shouldn't be scaring women. And this is going back a few years now that we were said this, but I think it's still a discourse that's around. So we interviewed some antenatal women and then interviewed the same women postnatally. And they said really similar things, actually. They need good sources of information. There is definitely an influence of healthcare professionals in their decision making and when and how women want information. So they want easy to access information like antenatally. But the key message from this, and I hope Carol won't mind me paraphrasing, is it's the same antenatally and postnatally, which bowled me over when the master's student Erin came into my office and was like, it's actually the same. People are saying the same. They want the same information. We always thought it would be different because until you've experienced labour, right? Maybe you want different information to once you have experienced labour. But that was not the case in this admittedly small sample of women, but nonetheless, I think that's really interesting. So then we've talked to staff as well. We've done a lot of talking, but this is important, I think, because this is about interpersonal interactions. So we talked to staff about what they're interested in. So they feel like they need to think about the context of decision making. So they feel like there's not enough time. Intrapartum decision making is challenging. There's loads of variation in practice. Like you speak to me, you speak to Professor Weech, you'll have a different conversation about a very similar topic. Like it won't be, I'd like to hope it won't be completely at odds with the facts, but the way we say it and communicate it will be different, right? And then it's also like the accessibility of decision-making conversations. So if you are a woman or birthing person with really amazing agency and you want to have an in-depth conversation about your birth choices, you will tell your midwife that early, who will refer you to a birth choices conversation, and you will sit and have the most fantastic conversation with a really senior midwife usually about what you want to do. Whereas if you don't have that agency and that ability to ask for that conversation, you just kind of bumble through your pregnancy having a conversation with a midwife who also has like 100 other jobs to do at every appointment. So there's like a real disparity in access to these conversations. And then the other thing we found out is that there is a bit of controversy. So there's people definitely bring their clinical expertise. We expect people to do that into a conversation, but people do also bring their personal experience into those decision-making conversations. And I think as clinicians, we need to think about that, reflect on it, and figure out a way of kind of declaring our a priori kind of influences. There's also conditions limiting the validity of consent, for example, intrapartum nature of consent. And there's real challenges that we face as clinicians when women decline medical advice, to follow medical advice. And I think that's like a whole other area to address another time. But, there are really some challenging things around informedness and consent. So we're kind of now at the point where we were thinking, okay, so we've identified from every way that it is a really good idea to give women some good information about birth that's evidence-based. But we need to deliver it in a really helpful way, and we need to have been on the journey with women birthing partners and maternity staff. So we started these co-design meetings where we sat around and said, how are we going to deliver? We had this 2-hour slot that we were given, and we were allowed to do a session in 2 hours. So we're like, how are we going to deliver information about labour and birth? Because at the place that I was working at the time, they had their kind of postnatal infant feeding session done. So they only wanted us to do labour and birth. So how are we going to do this? And we sat down and we planned it over a series of meetings. It was really, really informative and really good fun. And we co-designed a 2-hour labour and birth session, which 4 amazing midwives then went on to pilot test across 19 sessions with 143 women and 94 birthing partners. And this just allowed us to test out the intervention, to modify it a bit, and to figure out what people felt about it. So this diagram is unhelpfully small, but basically it says that people strongly agreed that they got a good set of information. And the top line is the mums and the bottom line is the partners. Well, actually, that's not true. The mums, the mothers, the women felt like they got a good set of information. But as you might notice, the line below is the partners, much lighter colour than the birthing people. And they didn't feel that they got like a huge, they didn't find that interesting. They didn't find it enjoyable. They didn't find they could ask questions very much. They didn't think that the information was that relevant to them. And so then we asked them, did you actually get the actual information? Do you know about vaginal delivery? Do you know about cesarean section? Do you know about assisted vaginal delivery? Do you know about induction? And it turns out they did. So they get the information, but they don't enjoy it if you're a birth partner. And women seem to and birthing people seem to like it more. So again, how are we going to bring these birth partners into this conversation if they're there, they get the information, but they really don't want to be there? So we've got to work on that. But we modified the intervention. We had loads of changes recommended by parents and midwives, and some of them were agreed on. And we just need to figure out the way to meet the information needs of partners. And the kind of overwhelming kind of feedback from the people attending the session was we need to do it for the postnatal session as well. So we've got this nice manual for midwives who can run the session, and anyone who wants it is very welcome to it. One of the things that we did, and I'll just mention this very briefly, is we had to measure expectations in this study because we wanted to see if we could shift them. And we were originally going to use quite a complex scale that is really good from a colleague of mine, Pauline Slade, here at the University of Liverpool. But it was considered by our kind of study group to be quite long and not always positive, which is actually a really good thing when it comes to psychometric scales, because actually having those negative elements in it makes it much more useful for actually measuring things. But it turns out women didn't like it, so we had to make a new tool. So we made a new expectations tool, which has enabled us to measure whether people's expectations of labour, and we can now measure whether it shifts across an intervention. So we have that data, and just resubmitting that for publication at the moment. So this kind of brings us to the fact that we've got, we've talked to women, we think we might understand what they want. We've developed a quick session that can be like a short, sharp intervention. So we've started to develop that. But actually, like, how are we going to put that into practice? It's like really, really difficult to implement something on the ground. And this is where the birth preparedness to antenatal education study was born. And basically, what we've done is go out and talk to policymakers and figure out what the current situation about antenatal education is on the ground. And together with women, we've come with this vision. So for every expectant parent to be offered a comprehensive, equitable, consistent, evidence-based programme designed to prepare them for pregnancy, birth and beyond. So we wanted to, and this is part of Nusiba's PhD, we wanted to figure out what antenatal education is available, what people think about it, what it should look like, and how can we achieve it. So we've done a survey of trusts, we've done a survey of parents and health professionals, policy, and we've spoken to policy influencers, and we've had co-production meetings. And yes, this sounds a little like what we've done before, but what we did before was pre-COVID. Largely, except for the actual implementation of the intervention, because we had the kind of COVID break for that. And this is all post-COVID. And we know that antenatal education has markedly changed, because when COVID came, antenatal education stopped, right? It was just shut down overnight because you couldn't have loads of people in rooms together. So we've surveyed trusts. Not all of them wanted to answer, but Nusiba's done a great job, and 54 of them have, and 70% of those trusts offer it to all parents, which is not, you'll notice what the NICE guideline says, but 8% only offer it for first babies. And there's a real variation in specialist provision, but there's a variety of formats that people offer it in. In terms of the parents that responded to our survey, nearly 450 parents, I'm doing the right time, 2/3 access some kind of antenatal education, but only 32% attended an antenatal education class, but loads of people access things on websites. Half of the women who didn't attend NHS antenatal education didn't even know it existed. So we've got something wrong there in terms of communication. But most women, 99% of them in our survey, wanted it to be part of routine care. But where do women want to receive their antenatal education? So you'll notice here that hospitals are a very small percentage. And currently we bring people together in various different places, but where women want to be is in children's centres, in community centres, in GP surgeries, in the community, close to home, not bringing people in. And then this is a point that I think I made earlier, that accessing antenatal education isn't cheap if you're not using NHS antenatal education. And in our study, the most frequently paid amount was £150 to £200. So this is like a key equity issue for us. Like, women should not have to pay to receive their antenatal education, which they need to support their labour and birth experience. What was really interesting to me, though, is that the professionals that we surveyed, and I'm sure some of you are listening and in this room, most of us, 86% of us, believe that women are getting antenatal education in the NHS. Also, most of us do believe that it should be part of routine care. But we need resources to deliver it, and the barriers, as with everything in the NHS, are money and time. And that graph's just to show you that a lot of obstetricians who are in the darker blue and a lot of midwives answered the survey, and a few other anaesthetists and educators as well. So this slide, I didn't realise it was going to be quite this small. I am sorry, but I'll talk you through it. So this is to say, how should we deliver antenatal education? So the kind of bar closest to us is in person only, and then there's online accessible resources, online videos, paper manuals. So some people, by the way, still want paper leaflets with important links. And so the point of this slide is to say that this is not a one-size-fits-all approach. Like, what we've overwhelmingly heard in the work that we've been doing with women in this project is that we can't just do it one way and that be acceptable for everybody. But this is my slightly reassuring slide, is that all of those bars are very, very vaguely similar in pattern. And what they tell us is that the green is what the trusts offer at the moment, the purple is what the professionals think that should be offered, and the blue is what parents think should be offered. So broadly speaking, I think we're at least offering the right kind of spread of information, even though I think we can probably do better about coverage and access. And so this is the kind of like, for us, Carol and I, who is one of the people working on this study, one of the really important bits, because this is where we've gone out and we've spoken to policy influencers who might actually be able to help us get some antenatal education into some kind of a curriculum or a policy that actually might make some change. So what we've found is that generally people think antenatal education should be part of antenatal care. There's mixed views of what the NHS currently offers and whether more research is needed or not. But the general feeling is that a national curriculum or standard would be valuable, but the resources need to be high quality, multidisciplinary, maybe involving the third sector and co-badging with different organisations to make them believable. And there has to be some kind of financial incentive to, like, it's got to be a requirement. So our co-design meetings then have brought us to this kind of final set of core principles for antenatal education. And I won't read them all out, but I will mention a couple. So one is that they've got to be positive, everyone's responsibility and consistent to support decision making. We've talked about many of these things already, but they need to dispel misinformation, follow the NHS guidelines and be free. So these are the core principles that we're currently working on with our antenatal education study, as we kind of try and take that forward into a roadmap and do more advocacy with our amazing links we've made with third sector organisations. So, is antenatal education the key to unlock the maternity crisis? Sort of. Definitely think it's part of it. There are definitely some other things that could help. But I just think, have I got a few more minutes, Andrew? Yeah. I just think that there are also some other things. So we definitely need antenatal education, but we also definitely need high quality information from the clinicians that you are seeing. And that is one of the things that we've been working on the NHR funded birth options study. So one of the things that I think has been really useful for us is a study that we did about risk communication. So we did an online randomized survey testing these 7 different ways of communicating information. And basically what we found is that people preferred the icons with the people in them. So that's one thing. But then also people got the answer right. People preferred the one with 10 people in it, is what they all said. But they got the answer right more often when there was 100 people in the picture. So we're going with 100 people in our pictures so that when we're communicating risk and talking about it, then that's kind of, our kind of baseline way of communicating is in these 100 people icon arrays. And Vicky Bradley sat there, who did this piece of work for a master's, thinking, I spent a year on that and you've distilled it into one sentence. Anyway, so let me do that for someone else's PhD. So this is the work done by another PhD student of mine, Alex Hunt. So then we're thinking, okay, so what information do we need to communicate? And one of the things that women tell us repeatedly is that they really don't like emergency cesareans. They do like good outcomes, and they do like choice, and they do like information, but they really don't like emergency cesareans. So we thought, well, let's look at this and think, like, how can we predict it? So we did a systematic review and we found there's loads of ways to predict emergency cesarean, but only 8 of them are validated and like low risk of bias. So that means we'd be willing to kind of use them potentially in clinical practice. But only 6 of those had a tool that me as an obstetrician can actually sit and put a couple of numbers into about a woman rather than get my calculator out and do complex maths. And only one of these 6 that existed, it's Gordon Smith's POPs model, actually predicted it at 36 weeks, which allowed you time to say to a woman, what do you want to do? Do you want to plan a cesarean? Instead of, oh, look, do you want to just have a cesarean today? Like, that's not a lot of time to think about it. And that, so that was the model that we kind of have gone started to work on. We've taken that as a baseline, and we've actually built our own prediction model, because Gordon Smith's model was really, really great and very robust, but it was only for a low risk population, and it didn't validate that well in the data we used from Bristol or Bradford. So we've built a new model, which we're just about to test. But along with that, we had to get the information that we give better. And we had to use the information that we'd found about how to communicate risk. So we've been through a process to develop these things that we call core information sets, which are basically the important points that women want to talk about when they're making decisions around birth. And I don't know if everyone will agree with these pictures, but this one here is vaginal birth, the lady with the peanut ball between her legs. And then we've got an induction of labour and we've got a caesarean section. And these are the 3 sets we've made. So we've gone through a kind of a robust process. I don't know if anyone's heard of core outcome sets, which is something that is kind of robustly developed in order to say what outcomes you should measure in clinical trials. We've used the same methodology to develop these core information sets, except we've made them look all pretty and have patient-friendly information at the end. So we've gone through this process with each of the ones we've done. We've got a vaginal birth core information set with 19 items in it, and this is the front cover of it. We've got a induction of labour core information set, which has got 12 overarching points, and all of these points have involved, you know, several hundred people in getting to these kind of points, and then loads of people in actually making the words right in the documents at the end. So they're really developed by parents and for parents. We're just the kind of the secretariat in the background, really. And then we've done caesarean birth as well. It's a bit trickier, caesarean birth, because actually you can be planning a caesarean birth with loads of, you know, time to chat from 20 weeks of pregnancy, or you could be saying I need to do a caesarean birth in the next 12 minutes. So we've got a set that you have you've got time to have a conversation. We've got these are the 5 points you need to know set, and we've got now you've had a caesarean, what do you want to know? Because what I did not know until we started this work is that women really value information like 30% of people in your situation have an emergency caesarean, because they're there thinking they've failed, they're the only one that's had that emergency caesarean. But we have the information that can support them in knowing actually that they're not alone. And I didn't even personally realise that would be vaguely important, but it was a really consistent message. So we put all of that into our postnatal kind of caesarean birth core information sets, which we hope can support kind of debriefing of patients. So I'll bring it back to say, is antenatal education the key to unlock the maternity crisis? Well, I'm completely biased, but I really do think it's hugely powerful. But it is not a replacement for high quality and personalised care. But it does also take, both personalised care and antenatal education, both do take time and money to do well. And so we can't step away from that fact, I don't think. But anyway, so part of the problem, part of the solution, definitely, Professor Weeks. So thank you very much to everyone who's taken part in the studies and the huge number of people who have actually made all this work possible, because it's certainly not an individual event. And any questions?
Stay there.
Don't.
Yeah. Thank you so much, Abby. Fascinating, and actually quite a complex area, isn't it? It's something which I think we thought in the past, we sort of slightly dismissed it maybe as obstetricians. It's not really clinical, but clearly absolutely vital. Questions, comments, thoughts?
I'd like to make a comment, because in 1972, which probably before some of the people here were even born, I actually ran antenatal classes. Now you might think, well, what qualifications have I got? I had none. I was in America, and I was fully qualified doctor in the UK, but I wasn't qualified in America. And in the village where I was living, small town, the women who ran the antenatal classes were actually lay. They were mums themselves. They perhaps had sisters or something like unfortunate experiences. And so they'd set up these antenatal classes. And the idea was for me to coordinate. Now, those who know me know that I'm a great organiser of things. They must have picked this up and they said, right, you can organise these. I was not qualified to say anything. But what I did was to get lots of different people to come to speak. So I had consultant obstetricians, I had midwives, I had people from the League, from natural childbirth. They all came to talk there was no cost. We ran it in. It was also, people like in America quite like to be seen to be doing social things for nothing. So we got the community centre. And also I went on the local radio. I contacted the local radio to advertise our classes. And they sort of do have some little speeches. So sometimes they have 2 minutes of free time from a local commercial station where I would talk about something to do with what we were planning for. But then you have dietitians, you have all sorts of people. I'm wondering how much, because I feel this is all very sort of NHS orientated. You're talking about private stuff being expensive, but I wonder if there is a tap of well-meaning, community-minded people in this country who would help to promote these sort of things. And your talk was really interesting. I wish I heard it said 50 years ago.
Oh, thank you. So I think the whole idea of like segments on the radio and things is like 100% what we're interested in trying to improve, because we need to get information out to people in ways they can digest it. And there's also an awful lot of work that I obviously haven't talked about that people in this room are working really hard on. And one of those things is actually what we've been undeniably told is people want videos with subtitles that last 1 minute and 30 seconds to 2 minutes, and that's how they want their information. So you're ahead of your time. We need to do that better. And I do think there are loads of people who would be willing to support that. But I also think that the overwhelming message that we've heard from the women in our study is that they want trusted NHS resources, because people are completely overwhelmed with the sheer volume of social media influencers and like things coming at them, which in no way is regulated. And actually, if you take on board everything that the social influencers say, maybe you're not getting the kind of high quality evidence-based information. So yes, I think there's a real space for that, but I think we need to do it like as trusted professionals with an evidence-based backup.
Thank you. Yeah, and Andy.
Thanks, Andy. I've worked with you for a few years now. That's the first time I've really understood everything I've done. So. I did have a question about you were talking about prediction models and that, and they're always tricky, because we feel that we need to give people choice, but sometimes we don't like the choice they make, and it feels difficult as a medical fraternity, I think, to do that. Have you got any evidence from other stuff you've done, or from other prediction models and other circumstances, of how people interpret risk or chance differently, and how they make those decisions based on, because you may give this information, you've got a 30% chance of having a cesarean section, and for one woman that's 100% chance, and for another woman that's a 0% chance, and there's every other spectrum in between. So we want to give the information, but we don't want to put our influence on it. And obviously the population who are viewing it will have their own views, but they might also be skewed by their culture, their background, their age, and all sorts of other factors that we will find hard to equate for on a pictogram of risk.
Yeah.
So.
Right. Okay. So it's very difficult, I would say. I think your point about, for one person that's 100% risk and for another person that's 0% risk is really, really important. And so how we actually communicate that risk is really very key. And we have done quite a lot of thinking about it. So first of all, the way that we're going to present our prediction model is not as a prediction model for someone to use at home on their own, but as a prediction model to use alongside a clinician to describe the risk and have more of a discussion around it. We've built this prediction model for emergency cesarean birth, and we're about to actually start doing the investigation that you exactly describe, because we're doing a feasibility trial to look at people. We're basically going to offer women to do one of three things: continue with their plan to have a physiological birth, to have an induction of labour, which we know reduces emergency cesarean section rate. That's probably one of the only things that's come out of a lot of the recent trials, or to plan a cesarean. And whether giving women the information and the prediction will result in them all choosing a planned cesarean or all choosing an induction or a vaginal birth, we've got no idea, because we don't really know how women respond, how people respond to this information. And usually what, in terms of prediction modelling studies, what often happens is you have a prediction model and then you test it out. It would not really offer as to whether the predictor work, like the prediction tool works, not about women's response to it. So that's what we're trying to do in this study, is to look at women's response to the prediction model with no, and it's a very small study because it's just a pilot study to hopefully go on and do a bigger trial, but with no, we've got no value based on what they choose. It's only about the woman making the right choice for them. Now, what I do really wonder, so we have a tool where we have, we have a picture of where the kind of population risk is, and then we have a set of words around it, which is, if there's 100 people with similar characteristics to you, then they might expect to have a cesarean birth in, an emergency cesarean birth in, whether it's 10% or 70% kind of cases, with the idea that we're really trying to doing our best to make people see that it's not like them that's going to have that outcome, but that this is the kind of risk. And we just wonder about whether showing people that risk, like some people, and it's about for me, it's about the woman being content with her choice and going into her birth positively, whether that's positive for a planned cesarean or positive for aiming for vaginal birth. Like, she's got to be on board and happy with her decision, because she, after all, we facilitate what we can. She's the one that has to live with it, with whatever happens, and hopefully we can make it as positive for her as possible. So watch this space, I would say. I'll tell you in a year.
Okay, thank you. Can I ask my question? No, don't escape yet. Yeah. It's been an overarching theme in the past that we've said we don't want to tell people about bad outcomes because we're going to cause anxiety, which will upset people. And you've shown in your focus group that that's not the case. But of course, you want to know about bad outcomes if you get one of those bad outcomes. Can we be sure that in your research you've not been receiving lots of information from those who had bad outcomes, because they tend to fill the consumer groups, and say, well, had only I known that I could have complication X, then that would have been easy. But actually, people who have gone through, had an uncomplicated, normal physiological birth come out at the end, and say, did I want to know that I could have died from postpartum hemorrhage? Well, probably not. But of course, if you have a bad outcome, then you want to know about it. Can we be clear from your research that it also affects those who had completely natural, normal outcomes? Did they still want to know about bad outcomes?
In the focus groups, yeah. They did. And we've had, so the people, like, I had this like amazing set of birth videos that I did for women, and we had a person on her fourth birth who had a beautiful spontaneous home birth, and we had people who've had water births, and then we had people who've made positive individual choices to have planned cesareans that went absolutely fine. Like, I think one of the things that I've been ultimately surprised about throughout all of this work is that, yes, women who've had poor outcomes, like the instrumental birth co-information set that we're currently doing that I haven't talked about tonight, really want to come and share their stories. Absolutely. But actually, women, this is an experience that so many people go through, and everyone has their own birth story, whether it, whatever happened, and women have been really willing to come and share those, and lots of them are really positive. But we have had obviously some people with poor experiences. But I do think, on the whole, what I've heard is that women want this information regardless of their outcome, which is why we've tried to look at it antenatally, postnatally, compare people postnatally and antenatally, because I keep thinking this isn't right, but that's why we've really done. And am I going to say it's perfect? No, I'm not going to say it's perfect, but have we done our best to know that people probably really do want this information, or at least decent access to it? Yes. And are we going to push this information down someone's throat if they say, I just don't want to talk about this? Then absolutely not.
Okay. So the take-home message for us as clinicians is stop being patronising, get on and tell people about everything. Okay. Yes, another question. Yes.
Thank you. I'd like to ask how strongly the subject related to the demographic problem, or is it that's a different field of study?
Waiting to the demographic in terms of the diverse community or decline of birth rate. Oh, okay. I'm not sure that antenatal education has the capacity to alter the birth rate. We know that the birth rate has substantially declined in this country, and it is obviously there's a big global issue. But I don't think that antenatal education is necessarily particularly related to that, because usually we only see people once they're already pregnant, so they've already taken that decision. Okay.
Can I open up a bit of a discussion about birth partners?
Oh, yes, please.
Because I mean, that's fascinating. That was what a fascinating slide. They learnt everything, but actually are going. But I didn't feel engaged. I didn't feel that I wanted to ask questions, and it wasn't for me. I mean, in truth, that's been my experience as well. If you go with somebody, and I guess if a partner's going to talk about your partner's footballer and you're going talking all about footballing injuries and you're talking all about that, and yet you're going, well, yeah, I learnt it, but it really didn't matter for me. How do we get around that? Because clearly birth partners are sort of a critical part of the process, and yet those classes weren't addressing their needs at all. And you just wonder whether actually it just needs a separate class or a half a class where you have core information and you split, because I suspect a lot of the partners would have loads to share, and their sort of anxieties and their concerns, but actually they wouldn't open up about it in a class with their partners or with other partners.
Yeah, and I mean 100%. I don't know the answer to this, Sandra, but I think you're right. Like we've not found a decent way to access this group of people who are absolutely core. And like men get postnatal depression too, right? We haven't discussed that at all today. And we need to find a way to access that group of people. But like, I hate to say it, I think it does come down to time, money and training again. Because until we actually have a resource that we can offer for that area, then it's very difficult for us to actually, even have a room where we could potentially invite people to have two parts of a class is really, really challenging. So I think it's something that we definitely need to work on.
Okay. Other comments?
Mostly male or female, because I would have thought that might make a difference.
So mostly male, but there were definitely some same-sex couples. And then there are also some people who, of course, their birth partners are their mum or their friend as well. So absolute variety, but mostly male partners, yeah. And it was interesting when we went to an Arabic speaking group, for example, with women who could only speak Arabic, and they didn't really want their birth partners to come along to antenatal education in the same way.
Okay.
Yes,
there you go. Yeah.
I suppose a lot of antenatal education, or certainly when I see women back postnatally, is there's that big disconnect between expectation, what you thought was going to happen, and what actually happened. And it's about that preparedness that you said about, these are your likelihood of having this experience of unassisted water birth in the pool, even though you're 42 and your BMI is 42. What's the likelihood of that being achievable for you? And people feeling disappointed. I'm ever the optimist believer, actually, as an obstetrician. And some of the prediction model does make me feel uncomfortable if you're told that your risk of a cesarean because of these characteristics is higher. The women might make an informed choice to have a planned cesarean section. We will never know whether they achieved the vaginal birth because they've taken that decision to not attempt it. And you talked about a colleague that was very upset about aiming for a vaginal birth and having it unplanned. When that is a reality for lots of women, do we need to make these unplanned cesarean sections better? And some of that information that I give women is, and I try and call it unplanned now instead of emergency, because actually a category 1 cesarean section is probably relatively rare, as in a bradycardia where we're running around, is actually, you can still have a nice experience having an unplanned caesarean section? And do we need to work on our education to what an unplanned caesarean looks like, so that women go into the operating theatre feeling that they've made, they've been part of that decision-making process, and whether it's the delay or presumed fetal compromise, is they feel safe, they're having a good outcome, so that when they're on the postnatal ward, it's not a failure to have an unplanned caesarean section. It might not be the birth plan that you were aiming for, but that you should feel positive, because I hope that there are women postnatally who've had an unplanned caesarean section that are happy.
I mean, especially to have a good outcome and a good experience, and I'm sure that there are. But I think you have to know that that's a possibility. I think in terms I think you're absolutely right. Like, unplanned caesareans do not have to be traumatic events, but I think what we've heard is that if you don't even know that if you sit down and you go through your usual antenatal, no, we've run over time, Andrew, I'm sorry. But if you go through your usual antenatal care and you don't go to an antenatal education class that tells you about caesareans, yes, you've heard about caesareans because everyone's in society's heard about caesareans, but you might literally have never thought that it might happen to you. And you just need to have that thought, right? I think that it might happen to you. Otherwise, it's really difficult to cope with. And I think one of the things I think is really going to be really interesting about this prediction model business is that actually, we might say to a woman who we would counsel as an obstetrician as someone who's having high risk of an emergency caesarean, but our high risk might only be 45%. And she's still got more chance actually of having a vaginal birth than she has of an emergency caesarean birth. And I wonder if that might be quite powerful for women in terms of supporting their choice, but knowing that it's a possibility that they're emotionally prepared for. I don't know the answer, but we might find out.
You're going to need to update this all the time, aren't you? Because you're chasing your tail. Because the more people choose opt for a caesarean, you'll say, oh, BMI 42, 99% chance of a caesarean. Well, it isn't actually, but they've all been seen the statistics and gone, oh, well, I'll have a caesarean. So
we're only predicting emergency caesarean.
It's sort of.
You've really got to test your prediction model before you start counselling people by using it, because it's the danger that could influence their decision making, isn't it, without knowing it's accurate.
And if you had taken it 10 years ago, it would be a very different prediction model, wouldn't it? As things change.
The data is up until 2021. It's that for our particular prediction model, it's developed in North Bristol's data, validated in Bradford, validated in Cambridge, and hopefully in the next 2 weeks validated in Liverpool. Now, does the prediction model perform extremely well? No, because there's an awful lot of factors that go into emergency caesareans, including people's choice, right? So, people, for those of you who are not in the kind of obstetric area, like if a woman sort of starts her, for example, her induction of labour and then says, actually, I've really changed my mind about this, we would then do an emergency caesarean section, and they would be included as an emergency in the current figures. There's a lot of data issues and a lot of other things that we need to address going forwards in terms of types of emergency caesarean that we need to think about. So it is a real challenge, the prediction model, which is why actually in this study that we're doing, we're testing three things. We're testing usual care, just having information about the three birth options, and the prediction model and three birth options, and we're seeing if there's kind of any difference between the groups. This is just a pilot study, but hopefully a full-scale trial come near you. But Helen, I really take your point, and we've really we've developed a prediction model, internally validated it, and we'll try and externally validate it in 3 data sets, to make sure we're being robust.
Okay, fantastic. Just fielding questions online as we've been going. I think some of the questions you've answered, but thanks for the question. The one thing you haven't answered is people love your leaflets. Are you sharing them online? Can they get them?
www.birthoptions.co.uk has most of the information on it. We're still finalising it. We're still updating that website at the moment, but they're also, if you just Google my surname and BJOG, 2 of them are published in the British Journal, BJOG, and there's a kind of, you can download them from there. Are they on the website? Can you download them? They're not. We can't download them from the website just yet, but we will be able to soon.
So check again in 2 weeks' time.
Yeah, when Vicky's finished her exam.
Okay. Is that 2 weeks or no? That's not even 2 weeks. 2 weeks, and you'll give you 2 days to put them on. Okay, perfect.
But yeah, there's supplementary files in the papers.
Oh, so they are available online on the papers.
Freely. The only one that isn't available yet is the induction of labour, because BJOG didn't want to publish that, sadly.
Okay.
No pressure.
I think wow, I've got a list of questions I want to ask. So you're staying around for a little bit afterwards. So please feel free to come up and ask Abi any questions. Thank you so much for that. Fascinating. And is it the key to unlocking the maternity crisis?
Partially.
I think you've shown that it's going to have a very major part in doing that. That improved communication, that improved way of working together. So thank you very much. We do have a little something which we would like to pass on to you, which is a medal, a gold. Is that a gold medal? Bronze medal.
That's better than publication any day, right?
There we go. Which is a rare and beautiful. Thank you for for what you've done. Actually, our next talk that we've got is in 3 weeks' time, and that's Professor Sue Down. So Sue is coming to speak to us about risk assessments. And do risk assessments work? And actually, the title of her talk is Risk Reduction. Do they actually increase risk? And the question is, if you do risk assessments, does it cause a problem rather than is it solving a problem? So that's on Thursday. This is on Monday because it's slightly different this week, but otherwise it's on Thursday, 19th of March. Links available online, so please do join. You'll also see some of the programs around. They're available outside. And they've got a list of all the upcoming lectures, which you either join in person or you can stream live online. So the previous ones are recorded, and you're very welcome to watch them. They're great. It's a members only link, and you're a member, presumably. I think isn't everyone a member here? They should. It's not. You don't have to be a member to attend the lectures, but why would you not be a member? Essentially, it's £50 a year, free for medical students. And we ask consultants in active practice to pay a little bit more. But then that subsidises the medical students. So isn't that wonderful? But then you get free use of the building as well, and a great place to bring friends and family to show off your heritage. So thank you very much. We'll leave it there. Thank you for those who are joining online, and we'll hope to see you again in 3 weeks' time, 19th of March for Sudan. Thank you very much. It's